And now may I invite our next speaker, Dr. Mallika Goyal. Dr. Mallika Goyal is Head of Retina Services at Apollo Hospitals, Hyderabad, and she will be talking to us about recognizing and managing vein occlusions.
Thank you, Dr. Mudit, and to Dr. Tinku Bali for this opportunity. So I'll keep it basic as I was asked to. When we see retinal vein occlusion, the first thing to look at and address is any comorbidities. Any hypertension, which is the most common comorbidity, diabetes, lipids, tobacco use, very important, homocystinemia, in more atypical cases, blood malignancies, and inflammation. And then we come to ocular therapy after addressing those issues. The first line therapy is serial anti-VEGF injections, and only then comes laser, steroid, or vitrectomy in specific cases. So first is systemic management, and only then is injections. Now, when we examine the eye, the most common ocular comorbidity and the risk factor for causing retinal vein occlusion is glaucoma. So look at the disc very carefully. It's very easy to miss early changes. And avoid steroid injections for the macular edema associated with RVO because IOP may rise. And likewise, for managing glaucoma, avoid the use of prostaglandin analogs and alpha agonists because these can increase the risk of recurrent macular edema with RVO. So as I mentioned, glaucoma is the commonest ocular morbidity but easy to miss. Examine the disc very carefully in every patient of RVO. It can be classified as central retinal vein occlusion or hemiretinal or branch. And central and hemiretinal can be ischemic or non-ischemic. Branch retinal vein occlusions can be one of the major veins or a macular branch vein occlusion. Now, ischemic CRVO and HRVO will present as a drastic vision loss, usually close to counting fingers at 3 meters or 6 meters, not better. Extensive hemorrhages, severe macular edema, higher rate of macular edema recurrence requires more injections. And sometimes there is not even much edema, but the vision is poor because of the severe ischemia. And most importantly, these eyes need vigilance for development of neovascularization of the iris and NVG, which is a very devastating condition. In contrast, non-ischemic CRVO and HRVO do not have such a poor presenting vision. Visual recovery is good and they need less number of injections. Now, HRVO is diagnosed when there are two quadrants involved, either superior or inferior. And in these patients, the significance is because the extent of involvement is greater, there is a higher risk for neovascularization of the iris and NVG. So this is a major branch vein occlusion, superotemporal, which is the most common, or it can be a macular branch vein occlusion. In macular branch vein occlusion, there is no risk of proliferative retinopathy because the extent of ischemia is very low. Now, what are the complications we may see in retinal vein occlusions? Initially, of course, the macular edema, which we start treating with injections. But later on, proliferative retinopathy in BRVO. Look for NVE, NVD, vitreous hemorrhage, and tractional retinal detachment. And for this, it's very important that every patient of BRVO is committed to an annual retina exam. It has to be told to them that even if vision is good, you have to come for an annual retina exam. As you see here, patient is asymptomatic, superotemporal BRVO with pre-retinal vitreous hemorrhage, and this requires scatter laser. Similarly, a patient not aware of any symptoms, but you see the NVD and requires scatter laser in BRVO. So every visit, look at the disc carefully and the periphery for new vessels. In CRVO, HRVO, we have to look at the iris very carefully and the angle gonioscopy for early signs of NVI, NVG. Now, what are the investigations required? The role of fundus photography is generally underestimated. If you see this, if you just see the OCT, there is no change. Vision has also not changed. But the hard exudates are increasing, which means that we need to be more aggressive in the treatment. Similarly, again, the OCT and vision have not changed much, but hard exudates have resolved, showing that treatment is helping the patient in some way. And similarly, macular hemorrhage cannot be captured by any other modality except by fundus photography. OCT angiography has taken over the role of fluorescent angiography and is non-invasive. It can pick up the extent of non-perfusion, any new vessels on the disc, new vessels elsewhere. So the role of fundus fluorescent angiography really remains to document the type of leakage to allow macular laser in BRVO most of the time. Also, in cases with hazy media, it can allow us to detect new vessels because fluorescent can allow us, may not be possible on photography or clinical exam. Fluorescent may also show up new vessels on the iris which were not suspected. Treatment is anti-VEGF injections, and this is the list that is now available, and steroids, 2 of which are available. Anti-VEGF injections are the first line of management because steroids have these 2 major complications: raised IOP and cataract. Which anti-VEGF? Well, there are many studies done recently. The SCORE study, the LEVO, and the Newton study. All of these comparing aflibercept to ranibizumab and bevacizumab and finding that aflibercept gives superior results in terms of efficacy and duration of action, reducing the treatment burden significantly. When to consider steroids then? Is there any role at all? I think the only role is when anti-VEGF are contraindicated, such as in pregnancy or recent cardiovascular events, or there is a severe renal dysfunction where anti-VEGF can worsen it, or when there is traction with active neovascularization where anti-VEGF can worsen the traction. What's the role of macular laser? This has a role only in branch vein occlusions for macular edema, but no role in CRVO or HRVO, possibly in HRVO in some cases. Scatter laser definitely is mandatory for all patients that have neovascularization. All patients with RVO have to be examined either annually or 6 monthly, depending on the severity and extent of ischemia. Each examination, intraocular pressure, undilated slit lamp exam of the iris and angle, especially in CRVO and HRVO. Look for glaucomatous disc at every visit, NVD, NVE, peripheral hemorrhages, traction, which can be easily missed and require laser, scatter laser. And very important, fellow eye examination. Very often there will be a silent RVO in the other eye. When CRVO presents with a disproportionately poor vision, there could be an associated cilioretinal artery occlusion, which makes the prognosis poorer. And this is the last slide on retinal vein occlusions in the young. Generally have a good prognosis, mostly idiopathic inflammation, though there could be an infection etiology. More commonly, blood dyscrasias, homocystinemia, or medication, including oral contraceptive pills. Generally, they need just 1 injection and they recover, do not need any more treatment, and get good visual acuity. We also had a few cases post-COVID infection and post-vaccine. Within days of Covishield in a young lady, and within 11 days of Sputnik vaccine in another young male. And the first one resolved without any injection, and the second one did need injections. Thank you.
All right, thank you so much, Dr. Goyal. Great talk and great cases. So just a question which probably will help all our colleagues over here. So the first line of treatment whenever you see a vein occlusion is essentially anti-VEGF agents.
First, as I said, find out what's the cause.
Yeah.
Whether it's hypertension and it's totally uncontrolled, patient is unaware. So first is to find out the risk factor. Before that, there is no touching the eye. Once we have identified and the patient has started management for that, optimal management, then yes, anti-VEGF.
All right, so thank you. So I think that's a very important message for everyone. It's important for a good systemic evaluation and for identifying the underlying systemic cause for why that vein occlusion has occurred in the first place, and then going ahead and treating the eyes. Often as ophthalmologists, probably we end up missing out on the fact that we also need to take care of their underlying systemic conditions. So that's a very important point coming out from this talk. So thank you so much.